So there's a lot of evidence that's come out now in the last, say, 10, 15 years. Do we start people who are diagnosed with MS, do we start them up front on something that's a little bit more highly efficacious and trying to get that early control of inflammatory activity? Or, do we kind of take this treat to target sort of approach where start them on more platform, moderately efficacious medications and sort of escalate if there's any breakthrough in disease? There's no definitive answer quite yet, but there is evidence that's leaning more so towards starting highly efficacious DMTs early, because we get that early control of inflammatory activity, and big prospective clinical trials like TREAT-MS are showing that we have less clinical progression for those people who started early. So through EDSS, the scores are better for long-term follow-up. So there is, of course, for many years now, there's been interest in CSF, but because of the invasive nature of having to do serial lumbar punctures on patients, who neither we or the patients, as you can imagine, would be keen to do, the interest in plasma biomarkers has skyrocketed. So being able to look at those same parameters that we look at in CSF, looking at those in plasma is very, very favorable. So things such as neurofilament light chain, glial fibrillary acidic protein, those are probably two of the most studied and most promising biomarkers, and there's many more, of course, that are coming down the pipeline. NFL, as we know, is more of a measure of relapsing activity. And then GFAP would be more of like disease progression. So those go into the secondary progressive phase, or for those who are diagnosed with primary progressive MS. So again, great interest in plasma because it's a non-invasive test. It's very easy to attain, it's cheap, and we can easily measure it at pretty much any MS center, across the country or across the world, really. So I was lucky enough actually to be the recipient this year of the S. Weir Mitchell Basic Science Award for Neurology Residents. So I was absolutely astounded and very, very humbled by that. So the data that we're going to present is just going to show the differential effect essentially on immune cell subsets between moderately efficacious and highly efficacious DMTs. So we had a great cohort in Newfoundland. It wasn't possible without the work of Dr. Craig Moore and all the people in his lab, where we have something called the HITMS database, which is the health research team in multiple sclerosis. So we have over 300 plus patients. It's a biorepository where we actually have PBMCs cryopreserved on file for many years now. And we have patients who we follow for many, many years. So clinical data and of course basic science research data, as well as rehab data as well. So what we're going to show in this specific project is that moderately efficacious DMTs differentially modulate the different immune cell subsets, so your CD4, CD8 T cells, your B cells, as well as your monocytes, compared to the highly efficacious DMTs. No real surprise probably that highly efficacious DMTs like ocrelizumab or ofatumumab, so B cell depleting medications, they deplete B cells more so than the moderately efficacious medications. But also that was really important, and it ties into the other CSF data, is that those B cells that are primed to go into the CNS, we call those the CD19 positive CXCR3 positive B cells. Those ones are dramatically differentially modulated depending on what DMT you actually use. So the high efficacious really bring those down, whereas the moderately efficacious ones do not. So that's sort of the big takeaway. Obviously, there's a lot more work to be done. I mean, this is the plasma cohort was more of an exploratory cohort, so we need to follow these patients and many more patients over a long period of time, correlated with EDSS, correlate with other clinical parameters that might be a little bit better, and correlate with MRI data as well, because there's lots of emerging MRI biomarkers that are very, very interesting. But I see it as part of one piece of a very big puzzle, but it does have an important part to play. Say, for example, in the data that I'll show in a couple of days, the differential modulation of T cells versus B cells in moderate or high. So if you have someone who's on moderate efficacious DMT, then you may want to measure NFL, but measure these particular T cell subsets with it because they correlate so well, and it'll allow to show if there's any disease activity. And then the same thing, of course, for those who are on highly efficacious. So one small piece of the puzzle, but important nonetheless.